When you're doing the Stiles screen and you have found a horizontal band of tightness that gets worse as you go out laterally, and we're thinking that the rib cage is the area of greatest restriction, the most important thing to stress is it is not that rib that is restricted. It probably at least 99% of the time is not the key rib. You have to screen the rib cage anteriorly to find your key rib. The best way I know to describe it is the rib that you feel posteriorly that has the hard infill is usually a compensatory problem, which is why so many people get frustrated with treating ribs, because they find it posteriorly, they treat it, they do different techniques, it improves some, but it never completely resolves. If that happens to you, there's nothing wrong with your technique, there's nothing wrong with your skill, that's not the key rib, and there's compensation going on. Until you get the compensations out, you cannot get it to freely move. So in the Stiles model, finding the horizontal band of tightness that's leading you to the rib cage says, I need to screen the rib cage and I need to screen the ribs anteriorly, where you're going to have maximal motion going on and you're not going to pick up other tissue texture changes. So to do that, the traditional way to do that is in the supine position. So I will show that first. And then an adaptation to being able to screen people in the seated position. So hand placement is important. So when I'm screening, and you're going to feel for first ribs, because first ribs, if you miss those, they can be key and can keep you confused and feeling frustrated. So for the skeletal model, so it's easier to see, when I palpate, I always start in patient, whether they're supine or seated, I always start out at the shoulders with blending palpation. Because if you come right in at someone, even though you said, I'm going to screen your ribs here, here, and here, do you have a problem with that? Always ask permission from your patient before you're going to screen them. This is kind of you're getting into their space and it's kind of threatening. But if I can come out to the side, establish my contact with blending palpation, slide my hands down when I hit where the curvature of the clavicle changed, so you kind of got that notch. When I hit that with my hands, I've been blending in, and for the purposes of the screen with the ribs, we want to blend to the layer of the bone. So we don't want to layer palpate to the bone, we want to blend in with the intent that we're feeling at the bony layer. So when I come in and I hit the knob, if I just slide my hands down and kind of just push them up a little bit, I'm going to be on the bottom edge of that first rib. So then I can drop my hands down right like this, and I can feel ribs 1, 2, and 3 all at the same time. Because if you screen individual ribs, you run the risk of making your patients lightheaded, dizzy, can make them hyperventilate. We don't want to do that. And we want to be efficient. We want to maximize what we feel. Now, for me, this works best, and I just divot my hands in. I keep my thumbs kind of hanging out, especially for female patients, so that your thumbs aren't touching breast tissue. Other people they come in from this way. If you come in from this way, you have to remember, you're not going to be able to get first rib. You're going to have to motion test that separately. So, and you don't have as good tactile sensory in this as you do on this part of your hand. You do what works for you, but just remember, if you come in to motion test ribs here, make sure you come to feel first rib, because those first ribs, if they're a key and you miss them, then you're going to be spinning your wheels as far as getting the rib cage opened up. Okay, so in the classic way that we learn to treat ribs, because in the supine position, your whole patient is grounded to the table. So it's very easy to blend in to the bone to feel what the mechanics are doing of the ribs. Just let you have your hands rest to the side there. So I'm right eye dominant, so I come in from the right side and ask the patient permission to be able to screen the ribs. I'm going to screen here, here, and here. So what we're feeling for, I'm going to come in so I can slide my hand down, and you'll hit the knot. If you slide like this, you're going to hit a roadblock, because you're going to hit where the angle of the clavicle changes. I call it the notch. So if you just slide your hand down and then slide up just a little bit, and again, I'm blending into the layer of the bone so that all my motion's going to be maximized there. If we just do this, and take a breath in there for me. When you do that, you're feeling all kinds of the soft tissue, the fascia, the muscles all together. But if I come and I just blend down till I hit the bone, Now, take a breath in and let it out. The motion's going to be much clearer and the feel is going to be clearer. So with this, I don't know if you can see it, but when you take a breath in, both sides are coming up. And when you breathe out, the left side's coming down, but the right side is not dropping down. So far, I know these upper ribs are inhaled. And again, the same thing, I try not to take my hands off the patient once I have established that, as long as you're touching them. So the next thing I'm going to do is I'm going to slide down like this. Now in females, you have breast tissue. To remember, in the supine position, gravity will naturally kind of have them kind of fall to the side. You've already asked their permission. So I take my hands like this because then I can take any tissue, and my thumbs are out of the way, and kind of pull the tissue so that I can then get right in on the ribs. And we don't want to be on the sternum. We want to be out a little bit so we can really feel where that motion is going on at that costosternal junction. Okay, now take a breath in. And let it out. Okay, now here, the right side's dropping down, but these left ribs did not come down as well. So far we've got two different groups of rib dysfunction going on. We've got a group up here that's inhaled, now we have a group here. Okay, when you come down to do the lower ribs, 6 through 10, the main motion you're feeling is coming from your mid-axillary line. I like to have my thumbs in the same plane of motion. They're listening. They're listening because the diaphragm is working in with the rib cage. They have to work together as a group. So I can already assess, is there diaphragmatic restriction going along with it? But my main thing is blending into bone, into the mid-axillary line. Okay, and then take a breath in. And I'm feeling what that motion is doing. And let it out. Okay, so left side came down, the right side did not. And even if you want to do a little screen, you can see there's spring here, but there is no adaptability here. Okay, diaphragm was a little sluggish on this side as well. I'm just taking in that information. So with regards to screening the ribs, the very important thing we have to remember is we have to treat the key rib. Ribs have a caveat. It is not only just what is the most restricted, it is going to be, you have in pattern and out of pattern ribs. So, and that's coming from Fred Mitchell Sr., and he is basing that off of the zinc model. So in pattern ribs are going to be, the right side should be exhaled and the left side inhaled, and that's an in pattern dysfunction with the ribs. So if the right side is inhaled or the left side is exhaled, those are out of pattern. So the important thing to remember is you're going to treat an out of pattern rib or group of ribs before an in pattern. So in our case, we had an in pattern group on the left here that was inhaled at about 3 through 5. We had 1 through 3 that was inhaled on the right, and then we had 6 through 10 that was inhaled on the right. So in his case, we have 2 group dysfunctions that are out of pattern. When you have 2 out of pattern dysfunctions, you have to determine which one was the more restricted. So if you remember, I gave a little spring. So this has a much harder infill and lack of adaptability. Here, if I come do the same thing, it gives, there's better spring, better tissue texture feel. So, and with the breathing, this had a more restricted feel. So in the case of 2 groups, you're going to treat the out of pattern group, and in this case, it would be ribs 6 through 10. And again, you follow the key rib is always going to be the bottom rib of an inhaled group or the top rib of an exhaled group. So for him and his dysfunction, I would want to treat rib 10. Okay, now that's the traditional way of screening, and then it doesn't matter your technique. What matters is that you get the key rib by screening the ribs anteriorly. So I'm going to show you an adaptation that you can screen the patients in the seated position. So I'll have you sit up for me. Okay. So using our blending palpation, this is very important. So with blending palpation, you have to establish a touch. So again, I'm going to come in, and instead of coming straight in at the patient, you've again asked for their permission to screen. I come from, because this is not as threatening if I come to the side, and I can kind of get my blending palpation, slide in along the clavicle, boom, I hit my little notch, slide down, and if I glide my fingers up, I'm on the bottom edge of the first rib. And I can drop my hands down so I can get 1, 2, and 3. Now, this is where it's going to be different from when if they were laying down, because laying down, we've already kind of grounded the patient to the table just by default of laying. But here, if I'm here and I'm trying to feel motion, everything is moving. So if you take a breath in, like you see, everything is moving. It's really hard to localize in. If I blend to bone, but then I want to ground my patient if they're seated, and I want to localize so they feel comfort and they're grounded to the table. You don't want to push back because then there's guarding. That's the natural thing to do when we say blend to bone, you push down and back. You just want to, you're blending, so we're not putting force. So you're blending. When you hit the bone, if you just do a little downward pressure after you blend, you'll feel that fascial drag. And when you feel the fascial drag, then you down, then you know that you've got the patient grounded. Now we can check that grounding because then same thing as before with our screen. When I spring, nothing moves. So I have everything localized here. I have the patient grounded, so there's no worry, the feeling like they're going to fall. That's very important with being able to feel the motion. As long as they're grounded, then the feel that you feel in your screen is the same as if they are supine. Okay, so so I got the bottom edge of the first rib. You're already picking up on tissue texture feel here. So there's already a difference in how the tissues feel here versus here. Even in motion, I think you can appreciate that. There's more pliability versus here. Okay, so take a breath in. Okay, both are coming up, and take a breath out. This side's coming down. This side is really sluggish. Matches what we found in the supine position. Again, I just take my hands and I slide like this because I don't want to lose contact. Okay, now take a breath in. And let out. Okay, these are starting to come down, and we had this group, so our screen is matching. These are inhaled. Okay, so if you have a female, it's a little harder, so you can either take your hands like this and kind of spread the tissue to fill in there, or I tend to do this. So as I slide my hands down, I've already asked, I can slide the tissue and blend in and get my motion right in there if I need to really feel what ribs 5 and 6 are doing. Okay, take a breath in and let it out. Okay, so rib 6 starts working over here. It starts getting caught up here, okay? Now, lower ribs, same thing. I'm going to get in at mid-axillary line. I like to take my thumb straight across the diaphragm. Remember, the main motion that you're feeling is coming from here. It's not here unless your focus is on feeling what the diaphragm is doing. So same thing, you got to blend into the bone, and then you're going to translate just a little bit back and forth and blend in and down until you feel that the tissues are grounded. And we can tell we're grounded because when we spring, patient's not moving. They're supported to the table. If I back up a little bit, they're going to be able to wobble all over, so it's going to be really hard to feel your localization. Okay, so now take a breath in. Both are coming up and out. This side comes down. This side does not want to come down at all. It has a much harder infill in the tissues, and there's no give or spring. So again, same thing applies, exact same restrictions. We had an inhaled group at 1 through 3. But there was a little bit of mobility and pliability in the tissues here. We had a group here at like 3 through 5, that was inhaled. And then we had another inhaled group at 6 through 10. So out of pattern, right should be down and left up when we're thinking of in patterns. If we think out of pattern with ribs, this is very key. The number one thing you have to remember is you have to treat an out of pattern rib or group of ribs before an in pattern. When you have 2 out of patterns, or for this case, if you even had 2 in patterns, you're always going to treat the more restricted rib or group of ribs. So of these 2, this was by far the most restricted group. So I would treat rib 6 through 10 on the right that are inhaled, and I would want to treat rib 10. Technique doesn't matter. What matters is getting the key rib. You treat the key rib with whatever technique that you're comfortable with. Treat it. When you get a release, you're going to go back and redo your screen because you can uncover other groups, or Sometimes you uncover individual ribs that can really be key to treat. So you want to, and once you rescreen each time you treat, and then once you have a symmetrical motion in the rib cage, most always the diaphragm will start doming. If there's still a hiccup in the diaphragm, that may be the next thing that you need to treat. But most of the time you get the ribs opened up, the diaphragm will open up with it. So you don't want to be poking and prodding all through the ribs, and we don't want to over-treat the ribs. So, but usually if you have the key rib, you're going to treat no more than 1 or 2, occasionally 3 ribs or groups of ribs.